Everyone. Here we are going to discuss a very important topic, that is thrombocytopenia. In your university exam, you usually get a long question on that. We will be discussing three important causes of thrombocytopenia here, that is ITP, TTP and HUS. Sometimes in your exam, you get short or very short question on these three types, that is ITP, TTP and HUS separately. So we will be discussing all of them here. Let's start the topic. Here you can see we are starting it, thrombocytopenia. So first of all, I will let you know the introduction. Then I will let you know the definition of thrombocytopenia. What is thrombocytopenia? Then we will see its two important types. Among the types, there are various causes. The three causes are important, on which separate question also comes in your exam, as I told you. So we'll be discussing them in detail, that is ITP, TTP and HUS. For each of them, I will let you know their introduction, their pathogenesis, the most important, clinical features and lab finding. So first of all, you should understand the overview, that what we are going to discuss ahead. So I request all my dear students always to understand the overview and to learn the overview. So if any question coming in your university exam, before start writing, it should be crystal clear in your mind that under what headings you are going to frame your answer. That's why overview is always important. So let's start it. So let me tell you the introduction of the bleeding disorders. I am assuming that you have already watched my session on the classification of the bleeding disorders. If you have not watched that, please watch it. So classification of bleeding disorders is important to understand it here. So, okay, let me ask you a question. What happens whenever we have injury on any part of the body? For example, I got a cut over here, or I got an injury over here. What will happen? Of course, I will bleed. Everyone bleeds whenever we have injury at any point of the body. So the next question, how long we bleed? We bleed for the next few minutes. After that, bleeding stop automatically. So the stoppage of the bleeding automatically is due to a physiological mechanism that is known as hemostasis. Hemostasis. Hemo means bleeding, stasis means stoppage. So the bleeding stops automatically after few minutes. How does it happen? So the injured area has to be sealed. So who is sealing the injured area? Let me draw a diagram to explain you in short. So you can see here is a blood vessel. Here you can see this is the endothelial lining, which is continuous, but here I am doing the disruption in the endothelial lining. So this is the site of the injury. So from here the person is bleeding. So first of all, we have to seal this area to stop the bleeding. So to seal this area, first primary clot is formed. So the platelet which are present in the blood, these platelet will come and seal this area. They will seal this area like this. So platelets are coming and they are forming the primary clot. I have explained in detail the mechanism of hemostasis in classification of bleeding disorders. The details are given there. You can watch that. So this is the primary clot I have formed. Primary clot is formed by platelet. That you have to understand here. The primary clot is made up of platelet that is sealing the area. So this is primary clot. For primary clot, we always require platelet. So you will see, ma'am, the area is sealed. What else now? What else we require? Now this clot is very fragile. If you don't stabilize it, it will re-rupture and the bleeding starts again. So we do not want that. So we want to convert the primary clot into secondary clot. We want to stabilize it. So how to stabilize it? Now in the blood, coagulation factors are present. Factor number 1 to factor number 12. So they will get activated. They all are inactive. Normally they all are inactive. So they will get activated one by one. They will lead to a cascade. So 12 lead to activation of 11, 11 leads to activation of 9. So there is a cascade, intrinsic pathway, extrinsic pathway, common pathway. Finally, the end product is factor number 1. So finally factor number 1 get activated. Factor number 1 is fibrinogen. So fibrinogen get converted into fibrin. That is the activation of 1. This is the last step. This is the last step. So out of the 12, 1 is last to get activated. So 1 will get activated. This one is like a thread. It's like a rope. So what this thread or this rope will do? This thread or this rope will stabilize the primary clot and convert the primary clot into secondary clot. So if you want to, so this thread like structure will wrap on the platelet clot, and now I will call the platelet clot as secondary clot. So secondary clot contain platelet was already there, but it is stabilized by fibrin also. So platelet plus fibrin is equal to secondary clot. But for fibrin, you require all coagulation factors. You require all 12. Fibrin cannot be activated directly. You require all 12. So the summary is that for the formation of primary clot, we require only platelet, and the formation of secondary clot, to convert the primary clot into secondary clot, along with the platelet, we require fibrin, and for activation of fibrin, we require all coagulation factor, and that is the secondary clot. So currently my topic of concern is thrombocytopenia, and for that I want to explain you the platelet. Now if any of the clot cannot form, either primary cannot form or secondary cannot form, the person continues to bleed. If the primary clot cannot form, Primary clot cannot form, so the problem is in the platelet. If the secondary clot cannot form, the problem is in the coagulation factor. Currently, I am interested in primary clot. Why primary clot cannot form? Imagine a person in which the primary clot cannot form. You will say, ma'am, why the primary clot is not forming? So there is some problem in the platelet. So what is the problem in the platelet? There can be two problems. Either the number of the platelet is less as normal. Normal platelet count is 1.5 to 4 lakh. So it is less than 1.5 lakh, 1.5 lakh per deciliter. So number is less. That's why the primary clot cannot be formed. Or else the number is normal, but they are non-functional. The function is not good. They don't have receptors on that. So although they are present, but they are of no use. So either there is a quantitative defect or there is qualitative defect. Either the quantity is not good, it's less, or the quality is not good, it's less. So there are two type of defects in the platelet. So currently my topic is thrombocytopenia. Thrombocytopenia means the number of the platelet is less. So that is known as thrombocytopenia. So to give you an overview, what do you mean by thrombocytopenia? I have drawn it and I have shown you where we are going to discuss. So we are going to discuss thrombocytopenia. Thrombocytopenia means the platelet are less than number. They are less than 1.5 lakh per deciliter. That's why the primary clot cannot form. And that's why the person continues to bleed. So it's the quantitative defect of the platelet, not the qualitative defect. So for qualitative defect, there is a separate session. There is a separate video. You can watch that also, the functional disorders of the platelet. And for the secondary clot defects, there is a separate video, that is hemophilias. You should watch that. Currently in this video I am going to discuss the quantitative disorders of the platelet, in which platelet are less than number. They are not in normal number. So let's start it. Now here in this video also you can see it again. So there is a injury, there is a defect. To seal that, first platelet are coming. You see the white colors are the platelet. First platelet are coming and sealing, and you see then the coagulation factors are coming. These coagulation factors causing the activation of factor number 1, that is fibrin. Fibrin is like a thread. Can you see this? These are the platelets now, over which if you can see the thread is forming and converting the primary clot into secondary. First primary clot is formed, made up of platelet, and now we will convert the primary clot into secondary clot by tying it with the thread. The thread is the fibrin. Appreciate the thread inside that. So you can see the thread is forming. So this is the secondary clot. So let's come on the topic. With this overview, now you will have a better understanding of the topic. Now we are talking about the bleeding disorders. Why the person is having bleeding disorders? Because there is a problem in the platelet. The primary clot cannot be formed because there is a problem in the platelet. As I told you, in the platelet there are two types of problem. Either the quantity is less or the quality is less. I mean the number is less. Quantity less means the number is less. Normal number is 1.5 to 4 lakh. So it is less than 1.5 lakh. So it is known as thrombocytopenia. Or else the second problem, sometimes the number is good, but they are non-functional. They don't have receptors. So this we will discuss in a separate session. Okay, so currently I am talking about thrombocytopenia. Now you tell me what is thrombocytopenia. I hope you have better understanding what you mean by thrombocytopenia. In thrombocytopenia, the platelet is less than 1.5 lakh per microliter. This is the definition of thrombocytopenia. So whenever the platelet is less than 1.5 lakh per microliter, for example, I'm the subject and I'm having platelet less than 1.5 lakh per microliter, and I got an injury over here. So my platelets are less. So primary clot will not form, and I will continue to bleed for longer as compared to a normal person. So this is the meaning of the thrombocytopenia. Here primary clot cannot be formed after injury. But imagine if the count is less than 1.5 lakh, if they are less than 20,000, it is severe thrombocytopenia. The platelet are hardly any platelet. Less than normal is 1.5 lakh to 4 lakh. Here the platelet is less than 20,000. So even without injury, person bleeds spontaneously. When the platelet count is less than 20,000, even without bleed, patient, even without injury, patient bleeds spontaneously. So that is thrombocytopenia. So learn the definition of thrombocytopenia. You understand what is PT and APTT? PT and APTT are used for secondary clot. It indicates coagulation factor. This indicates extrinsic pathway. This indicates intrinsic pathway. So here coagulation factor is not involved. They are normal. So that's why PT and APTT are normal. But here BT will be prolonged. What is BT? What is BT? The full form of BT is bleeding time. So imagine I got an injury over here. So the moment I got injury, I will start bleeding and I will start a stopwatch and see how long I am bleeding, I will take a filter paper and see still I'm bleeding, still. So a point will come when I will stop bleeding. It means the primary clot is formed. So as soon as the bleeding is stopped, I will notice the time for how long I have bleed. So that is known as bleeding time. So basically bleeding time is the indirect indicator of platelet function in human body. So if I'm having normal platelet, I mean normal in number and normal in function. The quality and quantity is normal. So if I have got an injury over here, I will bleed. I will bleed for 3 to 5 minutes. And after 3 to 5 minutes, the bleeding stop automatically. That is the normal bleeding time. But here, imagine I'm having less platelet, less than 1.5 lakh, and I got an injury over here. So I will continue to bleed more than 5 minutes. Why? Because here I don't have enough platelet to seal this area. So the primary clot formation is delayed. So here the bleeding time will be prolonged. So I hope everything is conceptual and you can understand it. Don't mug up the things, please understand it. So here bleeding time is prolonged, but PT and APTT are normal. Now, how many types of thrombocytopenia are there? Thrombocytopenias are of 2 types. How many types of thrombocytopenias are there? There are 2 types of thrombocytopenia. What are the 2 types of thrombocytopenia? You tell me. Megakaryocytic thrombocytopenia and amegakaryocytic thrombocytopenia. What do you mean by that? For understanding the 2 types of thrombocytopenia, you have to understand how does the platelets are formed. So all the blood cells, RBC, WBC, including platelets, they are formed in the bone marrow. So this is the bone marrow of a human being and this is the blood vessel of a human being. Now inside the bone marrow, there are megakaryocytes. Megakaryocytes leads to the formation of the platelet and platelet come in the blood. The megakaryocyte are the precursor of the platelet. They don't come in the blood. They are present in the marrow, but they don't come in the blood. Once they become mature and finally platelet is formed, the platelet is coming in the blood. So in the blood vessel, we have platelet. But in the bone marrow, we have megakaryocyte, which leads to the formation of the platelet. So megakaryocytes are the precursor of the platelet. This is how platelet synthesis takes place in human body. So this is normal. Okay. Now I'm talking about thrombocytopenia. So what is thrombocytopenia? The platelet are less than 1.5 lakh per microliter. Why the platelet are less? There can be 2 problems. Either the problem is in the marrow. The problem is in the bone marrow. The bone marrow is non-functional. You can see here. The problem is in the bone marrow. Inside the bone marrow, there are less hematopoietic stem cell or less megakaryocytes. Since the bone marrow is non-functional, less platelets are formed or no platelet are formed. So in the blood, you can see less platelets are there. So here the problem is in the marrow. So in the marrow, only megakaryocytes are less and that's why platelet are less. That's why such thrombocytopenia is known as amegakaryocytic thrombocytopenia. A means absent. The meaning of the A for absent. So here megakaryocytes are absent in the bone marrow. Since in the bone marrow the megakaryocytes are absent, it leads to less platelet, that is it is leading to thrombocytopenia. So A megakaryocyte is leading to thrombocytopenia. A means absent. The megakaryocytes are absent and that's why it is leading to thrombocytopenia. This is the first type. This is the first type. Here in the marrow the megakaryocytes are less and in the blood the platelet are less. Since the megakaryocytes are less, that's why platelet are less. So this is the first type. On the contrary, see the second type. Here blood is normal. On the contrary, there is no problem in the marrow. Marrow is absolutely healthy. Marrow is absolutely functional. It's healthy. It is having abundant of megakaryocyte. You say, ma'am, then what is the problem? If megakaryocytes are abundant of platelet will come in the blood. Yes, but there is problem in the blood. In the blood, there is something which is causing destruction of the platelet. Who is something? Maybe there is antibody which is present, maybe some thrombus is present, maybe some bacteria is present. Who is causing destruction of this platelet? So ultimately platelets get destroyed and in the blood their number is less. So thrombocytopenia here also. Thrombocytopenia means less platelet in the blood. So here also thrombocytopenia is there. But since in the blood there is less platelet, bone marrow will try to compensate. In the body there is always compensatory mechanism. So bone marrow will try to compensate and synthesize more platelet. So in the bone marrow there will be more megakaryocytes as compared to normal. So you can appreciate here the megakaryocytes are more and the platelets are less to compensate. So this one is known as megakaryocytic thrombocytopenia. So if you see the bone marrow, megakaryocytes are abundant. Even they are more as compared to normal to compensate. But if you see in the blood, there is thrombocytopenia. So here the problem is in the blood vessel. So you have to see where is the problem. Where is the problem? So if you have understood, it's good. Otherwise, you can learn the summary here. So in amegakaryocytic thrombocytopenia, the problem is in the marrow. And in megakaryocytic thrombocytopenia, the problem is in the blood vessel. So where is the problem? You have to understand that. So that is the meaning of thrombocytopenia. So what we have learned? We have learned there are 2 types of thrombocytopenia. What are the 2 types of thrombocytopenia? A, megakaryocytic thrombocytopenia and megakaryocytic thrombocytopenia. So what is the problem here? What is the problem in each of them? Can you tell me? So the problem is in the bone marrow or the problem is in the blood vessel? Here you tell me the problem is in the bone marrow or the problem is in the blood vessel. So the summary is that in megakaryocytic thrombocytopenia, the problem is in the marrow. The marrow is non-functional. That's why there are less megakaryocytes and that is leading to less platelet, leading to thrombocytopenia. But in megakaryocytic thrombocytopenia, the marrow is normal absolutely normal, healthy, and it is forming normal platelet. But after coming in the blood, there is some problem in the blood. There is some agent in the blood, and that agent is causing destruction of the platelet, and that is leading to thrombocytopenia. But to compensate, the megakaryocytes are more. Since the megakaryocytes are more, it is known as megakaryocytic thrombocytopenia. I hope you got it. I tried my best. So these are the causes. You can see the A megakaryocytic and megakaryocytic. So first we have seen A megakaryocytic. Now the A mega, how many causes of A megakaryocytic thrombocytopenia you know? So in all of them, the problem is in the marrow. The problem is in the marrow. So these are the causes. Can you see? These are the causes. In all of them, the problem is in the bone marrow. So either there is bone marrow failure, or there is vitamin B12 deficiency, folate deficiency, because they are required for DNA synthesis of the precursors in the megakaryocyte, or there is leukemia inside the marrow, or there is some cancer inside the marrow, or there is myelodysplastic syndrome in the marrow, or there are certain drugs which cause destruction of the marrow, destruction of the precursor cells in the marrow. They cause destruction of the megakaryocyte or hematopoietic stem cells in the marrow. So here the problem is in the marrow. Since the problem is in the marrow, less megakaryocytes, less platelet. So it is A megakaryocytic thrombocytopenia. Here the problem is in the marrow. On the contrary, see the problem here. The problem is not in marrow. The marrow is healthy. Here the marrow is healthy. Here the problem is in the blood. There is some agent present in the blood that is causing destruction of the platelet. So who is this agent? Who is this agent? So these are the agents. So there are various causes. There can be ITP, SLE, B cell cancer, drugs, who's causing destruction of the platelet in the blood. Or there can be TTP, HUS, DIC. So there are many causes. So we will be discussing three in detail. Which three? ITP, TTP and HUS. ITP, TTP and HUS, all three of them belonging to the category megakaryocytic thrombocytopenia. So in all of them, in all three, that is ITP, TTP and HUS, in all of them, the bone marrow is normal. In all of them, the bone marrow is normal, but there is problem in the blood vessel. There is some agent in the blood vessel which is causing destruction of the platelet. So who is this agent? In all of them, the agent will be different. So I will tell you the pathogenesis of all three, and in the end, we will compare all three. So ITP, TTP and HUS, they all three belong to which category? First, you understand, I'm going to discuss three important causes here. ITP, TTP and HUS. So all of three belong to this category. ITP, TTP, HUS. In all of them, the bone marrow is normal, healthy. There is no problem in the bone marrow. In all of them, the problem is in the blood vessel. So in ITP, as the name indicates, it's immune thrombocytopenic purpura. So here auto-antibodies are formed against the platelet and they destroy the platelet. In TTP, as the name indicates, thrombus thrombocytopenic purpura. So here a thrombus is formed in the blood vessel, and in that thrombus the platelet get consumed, and that's why it is leading to thrombocytopenia. In HUS, there is a bacteria, E. coli. The toxin of that bacteria will lead to thrombocytopenia. So the cause is different, the agent is different, but in all of them, the marrow is normal, healthy, and rather it is hypercellular. So that is the meaning. So I'm going to discuss three type of thrombocytopenia in detail. All of them are megakaryocytic thrombocytopenia. So first of all, we have seen the definition of thrombocytopenia. Then we have seen the types of thrombocytopenia. What is the definition? What are the types? In the definition, when the platelet are less than 1.5 lakh per microliter. So that is known as thrombocytopenia. The two types are A megakaryocytic thrombocytopenia, in which the bone marrow is involved, or megakaryocytic thrombocytopenia, in which peripheral blood, there is some problem in the peripheral blood. So we will be discussing three causes of megakaryocytic thrombocytopenia: ITP, TTP and HUS. So till now I have explained only this. Okay, so explanation was more for understanding, but you have to write only this. Now these three we will see in detail. Let's start one by one. So let's start with ITP. What is the full form of ITP? First learn the full form. ITP is immune thrombocytopenic purpura. ITP. Immune thrombocytopenic purpura. It is known as ITP. What is ITP? As the name indicates, immune. What do you mean by immune? Immune means antibodies. Okay, immunity is involved. So here the body is forming auto-antibodies against the platelet. So in the blood, platelets are present. What are antibodies? Antibodies are something which destroy the foreign cells. Antibody normally don't destroy the cell. In my body, antibodies are there. So antibodies are formed for the foreign particles and they destroy the foreign particles. Antibody don't destroy the cell. But here the auto-antibodies are formed. So these are the antibodies which are destroying human own cell. Which cell? Platelet. So that is why it is known as immune thrombocytopenic purpura. So the body's own immunity is leading to thrombocytopenia. Body's own immunity means auto-antibodies is causing destruction of platelet and leading to thrombocytopenia. And because of thrombocytopenia, the patient is bleeding and leading to purpura. And that is the meaning of ITP. It's type 2 hypersensitivity reaction. Here, the autoantibodies are formed. Let me explain you how does the autoantibodies are formed. It is of two type, acute and chronic. So we will be discussing two one by one. So let's start with acute. Acute occur in children. It is same in males and female. The incidence is same in male and female. So here what happens? The story starts with a viral antigen. Listen. Imagine this is a child. You can see the diagram. Imagine this is a diagram of a child, of a kid, of a child. Here in this child, there is a virus entering and the child is having infection of certain virus. We don't know the name of this virus. Okay, imagine this is a virus. This is a virus. So what will happen? You will say my body will form antibodies against the virus. It's very simple. So the body is forming antibodies against the virus. Actually, these are the antibodies formed for the virus. Okay, but the problem is that, what's the problem? On the surface of the virus, the antigens are present. The similar antigens are present on the platelet. Relatively similar antigens are present on human platelet. So basically, antibodies are formed for the virus. These antibodies are formed for the virus, but they will get confused. They think this is also virus because of similar antigen. So they will cross-react with the platelet and destroy platelet also along with the virus. So this is the mechanism of autoimmunity. Now, in the blood, there will be less platelet in the blood vessel. That is thrombocytopenia. To compensate, the bone marrow will synthesize more platelet and it will have more megakaryocyte. So in the bone marrow, if you check the bone marrow, you will get more megakaryocyte. And if you check the blood, you will get less platelet because of the destruction of the platelet by autoantibody. So this is the scenario. In the bone marrow, more megakaryocyte. In the blood, there is less platelet because the platelets are destroyed by the autoantibodies. I hope you are getting it. So that is the thing. So there is a viral antigen which is entering in human body in the children. So the body is forming antibodies, IgG antibodies against the virus. But since the virus and the platelet have common antigen, so the antibodies will cross-react with the platelet. What do you mean by cross-reactivity? Antibodies are not formed for platelet. Antibodies are formed by virus, but they are cross-reacting with the platelet and they cause destruction of the platelet. Since the platelets are destroyed by autoantibodies, it will lead to thrombocytopenia, the first mechanism. I hope you got it. This was the acute. Now coming on chronic ITP. Acute occur in children, chronic occur in adults. In acute, the incidence is same in male and female child, but in chronic, it is more common in female as compared to male. Here, no virus enters in human body. The body is automatically forming autoantibodies against the platelet. So these are the platelets. The body is forming autoantibodies against them without any reason. There is no cross-reactivity, no viral infection. That's the only difference. In acute, the autoantibodies are formed after viral infection, but in chronic, the autoantibodies are formed as it is without viral infection. And acute occur in children, chronic occur in adults. In acute, male is equal to female. In chronic, it is more common in female as compared to male. So that is acute and chronic. Here also autoantibodies are formed. So ultimately the antibodies are, the platelets are destroyed by the autoantibodies. So in the blood, there are less platelet. To compensate that, in the marrow, there are more megakaryocytes. So ultimate scenario for both of them is same, whether it is acute or chronic. Clinical features of both of them is same. So since the platelets get destroyed, the platelet get destroyed by the autoantibodies in acute also and chronic also. In both of them, the platelet get destroyed. Patient don't have platelet. Patient have less than 1.5 lakh platelets, so patient bleeds. So from where the patient bleeds? The patient bleeds in the skin. It is known as petechiae. It is known as petechiae and purpura. Patient have mucosal bleeding. Patient have, if the female is there is excess of bleeding during menstruation, that is known as menorrhagia. The bleeding can be from the nose, can be from the gums. The bleeding can be in the conjunctiva, you can see. In the conjunctival bleeding can be there. The bleeding can be in the stool, that is melena. The bleeding can be in the urine, that is hematuria. The bleeding can be in the brain, that is intracranial. So bleeding can be in the gums, in the nose, in the stool, in the urine, in the menstruation, in the mucosa, in the skin. Multiple bleedings can be there, and that is the clinical feature. What investigations would you do in such patient? For example, there is a patient coming to you and you are suspecting ITP, immune thrombocytopenic purpura, in that patient. What investigation you will see? You will do a CBC. In the CBC, you will look for the platelet count. Here the platelet count is reduced. The first thing you will notice, the platelet are less than 1.5 lakh per microliter. So number one. And if you make a blood film, see the two blood films in front of you. Can you see the two blood film? This one is normal and this one is a patient of ITP. Can you compare the two? Don't see RBC. These are RBCs. I'm not interested in RBCs. I'm interested in platelet. Where are the platelet? Can you highlight where are the platelet? Normally we can see the platelets are in clusters and they are abundant. In ITP patient, hardly I found any platelet. I found very less platelet. incidental occasional platelet, and that too not in clusters, that is singly. So on the peripheral smear also we get occasional platelet, and that too not in clusters, single platelet we are getting. If we measure the BT, that will increase. For example, I am the patient and I will have a needle prick injury over here, so I will bleed. If I'm a normal person, if I'm having normal platelet inside me, my platelet are more than 1.5 lakh. So here the platelet will come, make a clot, and I will bleed for 3 to 5 minutes. But if I'm having thrombocytopenia, my platelets are less than 1.5 lakh, and I got a needle prick injury over here. So platelet are less in my blood. In my blood, not enough sufficient platelets, so this area will not be sealed, primary clot will not be formed. I will continue to bleed for longer period, more than 5 minutes. So here BT will be prolonged. BT will be prolonged. You check the bone marrow of such patient, you will get access of megakaryocyte to compensate. That indicates that it is a type of megakaryocytic thrombocytopenia. It is not a megakaryocytic thrombocytopenia. Here the problem is not in the marrow. The problem is in the blood vessel. The blood vessel is forming auto-antibodies. Okay, so the megakaryocytes are more than normal to compensate. And in the blood, you will get auto-antibodies also in the patient. So that is the lab finding. So we are done with ITP. So out of the three, one is done, the ITP is done. Can I come on the TTP and HUS one by one? So let's start with TTP. TTP is difficult to understand. You got ITP. What is the ITP? What is the pathogenesis? What is the clinical features? What is the lab finding? So what is the problem in ITP? The auto-antibodies are formed. Auto-antibodies is causing destruction. Let's see who is destroying in TTP. What is the problem in TTP? What is the full form of TTP? TTP is thrombotic thrombocytopenic purpura. TTP. Thrombotic thrombocytopenic purpura. It is also known as Moschwitz disease. So that is the other name given here. So here there is a Pentad. I will explain all the 5 components of the Pentad. First you learn Pentad. In the Pentad, patient have thrombocytopenia. Start with thrombocytopenia because I am teaching you thrombocytopenia. This thrombocytopenia leads to 4 more things. It will lead to a anemia that is known as microangiopathic hemolytic anemia. That is known as MAHA. Microangiopathic hemolytic anemia. The thrombocytopenia is leading to microangiopathic hemolytic anemia. It also leads to neurological symptoms and renal symptoms. So the brain is involved and the kidneys are involved. Neurological symptoms and renal symptoms, and it leads to fever. So how it will lead to all, I will explain you. That is the Pentad in TTP. I'll explain you all 5 components. Please understand the pathogenesis. To understand the pathogenesis, you have to understand normal hemostasis. How does the normal primary clot is formed? How does the normal hemostasis takes place? First, I will let you know what happens normally, and then we will see the difference in TTP. What is happening in TTP? Okay, you can see a blood vessel over here. You can see this is the endothelial lining here, and it got disrupted here. Okay, see, normally it got disrupted here, I am saying. So this is the site of injury. So you already know what will happen. You will say, ma'am, the platelet which are passing here, they will come and they will make a clot. I'm interested in primary clot. The primary clot will be formed. So how does the primary clot is formed? Have you watched my session, my video on classification of bleeding injuries? Classification of bleeding disorders, in which I have explained the hemostasis steps in detail. You should watch that if you have not. Here I'm just summarizing it. How does the primary clot is formed? For formation of primary clot, the platelet will come and platelet will bind here with the subendothelial tissue. Where is subendothelial tissue? This is subendothelial tissue. You can notice. This is subendothelial tissue. So platelet cannot bind directly with the subendothelial tissue. They require a bridge. I'm interested in that bridge. What is the name of that bridge? The name of that bridge is von Willebrand factor. So here von Willebrand factor is there. That is causing attachment of the platelet with the subendothelial tissue. It is acting like a bridge. I'm making the bridge with the help of these small triangles. These small triangles is von Willebrand factor. Von Willebrand factor is there. Okay, this one is von Willebrand factor that is acting as a bridge, and it is connecting the platelet with the subendothelial tissue, and now platelet will bind with the platelet will bind with the platelet like this, and the primary clot is formed. So this is how primary clot is formed normally. Okay, now why does this von Willebrand factor normally do not act? It is acting only after injury, because to destroy the von Willebrand factor, we require an enzyme. The name of the enzyme is von Willebrand factor metalloproteinase. This is the enzyme which causes destruction of von Willebrand factor. Okay, and for the synthesis of this enzyme, we require a gene. The name of that gene is Adamst 13 gene. So this is the gene that makes this enzyme. So this Adamst 13 gene make this enzyme, and this enzyme, you can see this enzyme, just a second, okay? Give me a minute. So here you can see this is the enzyme, and that causes, here I cannot use the pen. Okay, just give me a minute. It's gone. So anyways, I have to draw it again. So here that enzyme is required. I will draw it quickly. So I will draw only normal. In that only I will explain you the TTP. So here this is the endothelial lining I have said. Here it is disrupted I have said. And you can see here is the area of the injury. Now in the area of the injury, the platelets are coming and forming the primary clot like this. These are the platelets who are coming and forming and sealing the injured area. This is the primary clot made up of the platelet. But I told you the platelet cannot bind directly with the subendothelial tissue. They require a bridge. Who is the bridge? The bridge is the von Willebrand factor. You can see this is the bridge. That is the von Willebrand factor. Now this von Willebrand factor is destroyed. Let me write down. This is von Willebrand factor. This von Willebrand factor is destroyed with the help of an enzyme. The name of that enzyme is von Willebrand factor metalloproteinase. Metalloproteinase. And for synthesis of this enzyme, we require a gene. The name of the gene is Adam's 13 gene. So this gene synthesizes this enzyme, and this enzyme causes the destruction of von Willebrand factor. This happens normally. So there is a balance of von Willebrand factor. It synthesized, it get destroyed. Again it synthesized, again it get destroyed. So there is a balance of von Willebrand factor. Now imagine if this gene is mutated. You tell me what will happen. So that is happening in TTP. In TTP, this gene is mutated. Oh my God. If this gene is mutated, this enzyme cannot be formed. So von Willebrand factor metalloproteinase is non-functional, or it is not formed because the gene for that is mutated. Since this enzyme cannot be formed, the von Willebrand factor cannot be destroyed because it is the enzyme which is causing destruction of von Willebrand factor. So von Willebrand factor quantity in the blood excessively increased. Excessively. It is synthesized but not destroyed. It is synthesized but not destroyed because the enzyme required for the destruction is not there because the gene for that is mutated. So that happens in TTP. You will say, ma'am, what will happen if von Willebrand factor is an excessive? What is the problem? Normally, the von Willebrand factor is active only when the injury is there. Can you see here the injured area? Then only it gets activated and it connects the platelet with the subendothelial tissue and form the clot. When it is excessive, no. So this is a normal blood vessel. There is no injury. You can see the endothelial lining is continuous. There is no injury. Mind my words, there is no injury. So even without injury, the von Willebrand factor, since it is excessive, it will form a clot. It will form the primary clot. It will combine the platelet with the endothelium because it is excessive, because it is not destroyed. So it will combine, it will join the platelet with the endothelium and it will make a clot without injury. Clot after injury is useful, but here the clot is formed without injury. So it's a disease. It is known as thrombus. So here the thrombus is formed. What is the reason for thrombus formation? The platelets are not culprit. Who's the culprit here? The culprit is a von Willebrand factor. It's an excess. It is an excessive quantity because the enzyme which destroyed, that is von Willebrand factor metalloproteinase, that is absent because the gene for that enzyme Adam's 13 is mutated. So in TTP, the Adam's 13 is mutated. So von Willebrand factor metalloproteinase is non-functional. So von Willebrand factor is an excessive quantity. So even without injury, it forms the clot, and that is known as thrombus. You say, ma'am, then what? What if the thrombus is formed? What is happening? All the platelets are unnecessarily utilized in that. Unnecessary utilized in that. Now if there is a real injury, platelets are not there, and that is leading to thrombocytopenia. All the platelets are utilized in clot formation, in thrombus formation. Multiple thrombus are formed, so all the platelets are utilized. Now if you see the count of the platelet in this patient, you will get less than 1.5 lakh. Where are the platelets? Are they destroyed? No. They are not destroyed by some auto-antibody or some bacteria. No. They are not utilized, they are not destroyed, they are consumed. You will say they are consumed. They are not destroyed, but they are consumed. They are not available now. So that is leading to thrombocytopenia. So I hope you got it. The mechanism was difficult, but not very difficult. So here the enzyme, the gene Adam's 13 is mutated. Since Adam's 13 is non-functional, the von Willebrand factor metalloproteinase is non-functional. Since this enzyme is non-functional, the concentration of von Willebrand factor is increasing in the blood. So since its concentration is increasing in the blood, even without injury, it will form the primary clot that is leading to thrombus. So since all the platelets are consumed in thrombus formation, that leads to thrombocytopenia. This is the mechanism. I hope you got it. The clinical features are same. Here also the petechials are there, easy mucus mucosal bruising is there, conjunctival bleeding is there, nasal bleeding, gum bleeding, stool bleeding, urine bleeding, and menstrual bleeding, brain bleeding. So all the bleedings, the symptoms are exactly same as that of ITP. Only additional finding here, small thrombi are formed. Small thrombi are formed. Can you see? Let me draw a blood vessel. Inside this blood vessel, there is no injury. You see, I'm drawing the lining as continuous. There is no injury. Even without injury, small thrombus are formed. These are the platelet clots. Even without injury, who is making these clots? The von Willebrand factor. Since the von Willebrand factor is excessive, so it is making the multiple clots over there. Now imagine this is a RBC which is passing from here. It's a RBC. So what will happen? Since multiple thrombus are there, RBC will come and collide with the thrombus and get ruptured. So multiple RBCs get ruptured, multiple RBCs, and it will lead to anemia. So such anemia is known as microangiopathic hemolytic anemia, MAHA. What's the full form of MAHA? Microangiopathic hemolytic anemia. Here anemia is there. The RBCs are hemolyzed. They are destroyed. But who's causing the destruction? The thrombus. Thrombus means microangiopathy. So microangiopathic hemolytic anemia will be there. Now in which blood vessels these thrombus are most commonly formed? The thrombus are mainly formed in the renal blood vessels. So kidneys are involved, and they are formed mainly in the brain blood vessels. So neurological symptoms are there. So patient have renal symptom, patient have neurological symptom because of the thrombus. And since the RBC get collide with these thrombus and RBC get ruptured, it leads to MAHA also. And since all the platelets are consumed here, the platelet in the blood are less. That leads to thrombocytopenia. So I hope you got it completely. I'm writing the mechanism again. Have a look. So what is happening? So here the main problem is ADAMS 13 gene is mutated. Since this gene is non-functional, the von Willebrand factor metalloproteinase enzyme is not formed. Since this enzyme is not formed, von Willebrand factor quantity in the blood excessively increased. Since the quantity is excessively increased, even without injury, it will form the primary clot that is known as thrombus. So multiple thrombus are formed in the blood. Now during the formation of the thrombus, all the platelets are utilized, and that leads to thrombocytopenia. Thrombocytopenia will be there because platelets are utilized. Now these thrombus are formed in which blood vessel? Mainly in the renal blood vessel and in the cranial blood vessels. So patient have neurological symptoms and renal symptom. And with this thrombus, the RBC will get collide, and that will lead to anemia that is known as MAHA. So you understood the 4 components out of the 5. So thrombocytopenia, renal symptoms, neurological symptoms, MAHA, and the 5th is fever, the Pentad of TTP. And what is known as TTP? What is the full form of TTP? Thrombocytopenic thrombotic purpura. So it is the thrombotic thrombocytopenic purpura. So thrombus are there, which is leading to thrombocytopenia. Who's leading to thrombocytopenia here? The thrombocytopenia is due to the thrombus formation. So I taught you 2 things, ITP and TTP. If you see their full forms, you will get the meaning. In ITP, the immune system is leading to thrombocytopenia. Immune means autoantibodies. The autoantibodies are leading to thrombocytopenia. And here thrombus is leading to thrombocytopenia. Here autoantibodies are coming and destroying the platelet. That's why the platelet are less. Here the thrombus is formed. The platelet are consumed in the thrombus formation. That's why platelet are less. Since the platelet are less, it is leading to purpura in both of them. So I hope the concept is crystal clear in ITP and TTP. So here additional finding, you will get the thrombus mainly in the brain and in the renal. And MAHA, the symptoms of MAHA can be there. So in the lab investigation, they are saying platelet count, if you see, it will be less than 1.5 lakh, of course. If you see the peripheral smear, occasional platelets are there, not in clusters, it's singly. The BT will be more, but PT and APTT are normal. In the bone marrow, there are more megakaryocytes to compensate. And yeah, additionally, if you do the biopsy, you will get the thrombus. Multiple microthrombi in the blood vessels are there. So we are done with 2. Out of the 3, 2 are done. ITP is done. TTP is done. You get separate question on them. If you're getting a question on overall thrombocytopenia, you have to describe all 3. But if you're getting a separate question on them, you have to write that portion only. Now coming on the 3rd and the last one, that is HUS. What is HUS? What is the full form of HUS? Hemolytic Uremic Syndrome. HUS, Hemolytic Uremic Syndrome. So here instead of Pentad, we have only Triad. Instead of Pentad, we have Triad. So from the 5 things, we will reduce 2. So the neurological symptoms are removed and the fever is removed. The remaining 3 are still there. So MAHA, microangiopathic hemolytic anemia, renal failure, and thrombocytopenia is still there. So let me explain you what happens here. It is of 2 types, typical and atypical. Typical is more important. So we will see the details of typical. So what happens here? The patient is having infection by a bacteria. You have to learn the name of the bacteria. The name of the bacteria is E. coli, a special stain of the P. coli, a special strain. It's O137H7. A special strain of E. coli is O137H7 that secretes a toxin. The name of the toxin is Shiga-like toxin. That Shiga-like toxin, what it will do? Let me draw the diagram. So you can see here. So here there is a blood vessel. And this blood vessel don't have any injury. You see the endothelial lining. I'm drawing it continuous. There is no injury. Okay. Now in this blood vessel, the bacteria is entering. The name of the bacteria is E. coli. What is the name of this E. coli? O137H7. It's a special E. coli. Okay. It will secrete a toxin. The name of this toxin is Shiga toxin. So this is the Shiga toxin or Shiga-like toxin. So this E. coli is secreting a Shiga-like toxin or virotoxin it is secreting. What does it do? What does this toxin do? This toxin will compel the platelet to form the thrombus even without injury. So the platelets are coming and making the primary clot here. The platelets are coming and making the multiple small clots. That is, platelets are making the thrombus without injury. Since it is without injury, it is thrombus. So who is forming the thrombus here? The thrombus is not formed by von Willebrand factor. Here the culprit is the Shiga-like toxin, which is secreted by the bacteria. So bacterial toxin is activating the platelet even without injury. Normally after injury the platelet get activated and they form the clot. Here without injury the platelet get activated by this toxin and platelet are forming small multiple thrombus. So the same thing, all the platelets are consumed in the thrombus formation. If you check the number is less, so that leads to thrombocytopenia. But here they are mainly formed in the renal vessels only, they are not formed in the brain vessels. So patient have only renal symptoms, patient don't have neurological symptoms. And here also the RBCs will come and collide. RBCs are coming and colliding and getting ruptured. So MAHA is a feature here also. So that is the triad here. So here the Shiga-like toxin is secreted by O157H7. That is the bacteria that is secreting a toxin, Shiga-like toxin, also known as virotoxin. That is causing activation of the platelet even without injury, and multiple thrombus are formed. So here in the lab findings of HUS and TTP, you can see these are the ruptured RBC I'm talking about due to the MAHA. Can you see? The RBC get fragmented, the RBC get ruptured because they are colliding with the thrombus. So they have various shapes, abnormal shapes. So they can have any altered shape. These are known as cystocytes. The fragmented RBCs are known as cystocytes. Sometimes they are helmet shaped. Burr cells and target cells are common. So that is the lab finding. So we are done. Can we compare the three? ITP, TTP and HUS. Can you help me in comparing the three? So I taught you three types of thrombocytopenia in detail. ITP, TTP and HUS. So can you tell me the introduction in all three? In ITP, it is the auto-antibodies are formed against the platelet that is causing destruction of the platelet. In TTP, there is a Pentad. Can you enumerate the Pentad? In HUS, there is a Triad. Can you enumerate the Triad? So what is the Pentad here and what is the Triad here? In both of them, the story starts with thrombocytopenia. So here also thrombocytopenia, that is our chapter right now. Here also thrombocytopenia. Here thrombocytopenia is due to multiple thrombus formation. Here thrombus is formed in renal blood vessel and the brain, neurological. So renal and neurological both are there. Here only renal is there, neurological is not there. Okay, here with the thrombus, the RBC get collide and leading to anemia, that is MAHA, microangiopathic hemolytic anemia. Here also microangiopathic hemolytic anemia. RBCs are colliding in both of them, leading to cystocyte formation. And here fever is the additional finding which is not there. So out of the 5 here we have only 3. So that is the introduction of all 3. I hope you got the introduction. Now can you tell me the pathogenesis? So as I told you here, it is of 2 types, acute and chronic, ITP. In the acute one, the virus is entering in human body. The body is forming antibodies against the virus, but the virus is having similar antigen as that of platelet. So these antibodies are auto-antibodies. Actually, they are destroying the virus, but they are destroying the platelet also. Since they are destroying the human own platelet, that leads to thrombocytopenia. Here there is no triad, no pentad, only thrombocytopenia is there. So here you can write down only thrombocytopenia. Here only thrombocytopenia is there. Here along with thrombocytopenia, other 3 things are there, 4 things are there, 2 things are there. But here only thrombo. So point is that thrombocytopenia here also, here also, here also. Here no triad, no pentad. Here we have pentad, here we have triad. That is the introduction. Now tell me the pathogenesis. In the acute, I told you the virus is entering. In chronic, there is no virus. Body directly forming autoantibodies against the platelet. We don't know the reason, and it is causing destruction of the platelet. Acute occur in children, chronic occur in adults. So that is ITP. As the name indicates, it's the immunity which is causing the thrombocytopenia. So that is ITP. Now coming on TTP. In TTP, the problem is that there is an enzyme. There is a gene. The name of the gene is Adam's 13 that got mutated. In some persons it is mutated. What does this gene do? This gene form an enzyme. The name of the enzyme is von Willebrand factor metalloproteinase enzyme. Now since this gene is mutated, this enzyme will not form. What does this enzyme do? It causes destruction of von Willebrand factor. Since this enzyme is absent, so von Willebrand factor is an axis. Since it is an axis, even without injury, it forms the clot. So this is known as thrombus. So multiple thrombus are formed. So platelet get consumed in the thrombus formation, and that leads to thrombocytopenia. So here the reason for thrombocytopenia is the thrombus. So thrombus is leading to thrombocytopenia. That is TTP, thrombotic thrombocytopenic purpura. And in HUS there is a bacteria. The name of the bacteria is E. coli. There is a special strain of that bacteria, O157H7, that secrete a toxin. The name of the toxin is virotoxin or Shiga-like toxin. That causes activation of platelet even without injury. Here, excess of von Willebrand factor was the culprit that is causing activation of platelet without injury. Here, virotoxin is the culprit that is causing activation of platelet without injury. Here also the platelet form thrombus without injury. So all the platelets are consumed here, and since no platelet is there, that will lead to thrombocytopenia. So here the platelets are destroyed by auto-antibodies. Here the platelets are consumed because of thrombus formation due to excessive von Willebrand factor. Here also platelet get consumed because of excessive thrombus formation because of the virotoxin secreted by E. coli. So the pathogenesis is important, but the symptoms more or less in all of them is same. Patient bleeds from multiple sides. The patient is having bleeding over the skin, that is paticky, bleeding from the nose, bleeding from the gums, bleeding from the ears, bleeding in the conjunctiva, bleeding in the urine, bleeding in the stool, bleeding in the menstruation. That's the various bleeding. Lab findings you can write down. So that is all about it. So I hope you got the topic crystal clear. Don't forget to check the long, short, very short question, including the MCQs of this topic, which are given in the notes section as well as question bank section. So thank you so much.